Good afternoon and welcome to this year's 2026 Refugee Week TransFORUM. My name is Nadia Garin and I'm representing Maria Casaniti, Manager of the Transcultural Mental Health Centre, who is currently on leave. The Transcultural Mental Health Centre is a New South Wales Health statewide service and focuses its work with health and related professionals and a range of organisations to promote and enhance the mental health and wellbeing of culturally and linguistically diverse communities across the lifespan and migration experience. This year, we have collaborated with the University of New South Wales Refugee Trauma and Recovery Program, otherwise referred to as the RTRP, a research program dedicated to understanding the psychological and neurobiological effects of refugee trauma and pathways to recovery. Before we begin, I'd like to acknowledge the Darug people as the traditional owners and ongoing custodians of the land where we are hosting this forum from today. I pay my respects to the Darug elders, past and present, and extend that respect to First Nations people that may be here with us today. As we are online, I'd like to also acknowledge the many other traditional countries and language groups that everyone is meeting from as well. TMHC celebrates and embraces diversity, from the world's oldest continuous culture of our first Australians to the cultures of our newest arrivals from across the world. We acknowledge people with lived experiences as migrants or refugees and their families with us today, and the courageous journeys of many generations of Australians who have made Australia what it is today. The TMHC also acknowledges the individual and collective contributions of those with varied lived and living experience or experiences, and those who love, have loved, and care for them. During Refugee Week, we also acknowledge the strength and resilience of refugees, those seeking asylum and displaced people in their search for a life free from fear and persecution. We recognise the unique experience of their journey, and we support their arrival and settlement and wholehearted participation in Australia. And finally, thank you. A warm welcome to everyone who is attending today, who came from many mental health and related social services across New South Wales and beyond. Thank you especially to our speakers, Professor Angela Nickerson and Dr. Philippa Specker today. World Refugee Day 2026 is this Saturday and commemorates the anniversary of the 1951 Convention relating to the status of refugees. At the global level, the WHO campaign, together with the UNHCR, or the United Nations High Commissioner of Refugees, the UN Refugee Agency and partner agencies, focuses on the inclusion and solutions for refugees to ensure their access to health services anywhere, anytime. Locally, the Refugee Council's theme for Refugee Week this year is A Million Stories. It signifies the number of permanent humanitarian visas that have been issued since the end of World War II. 1 million people who have contributed to the Australia we know today. We are invited to honour this milestone and the 1 million stories behind it. Each individual story and journey is unique, each one powerful, and together they have shaped our shared home. Every arrival carries experience of loss, resilience, hope, and often trauma. These journeys ripple across generations, influencing families, communities, and the broader Australian story. As we celebrate, we also look forward. How do we continue to welcome people seeking safety, not only with open doors, but with meaningful mental health support? How do we ensure access to compassionate, culturally informed mental health care? And how do we, as health professionals, foster understanding, belonging, and recovery? The New South Wales Refugee Health Plan 2022 to 2027 recognises that meeting the health needs of people from refugee backgrounds is critical to successful settlement and integration. One of the priority areas identified in the plan is timely access to mainstream public healthcare services, including mental health care. A practical tip offered in the plan is to provide prioritised access to timely interventions for the most vulnerable consumers, while also collaborating with specialised refugee health services and refugee community organisations. And so today we are here to present with RTRP practical tips to be able to work on the identified priority issue. Therefore, today's learning objectives are threefold. One, to outline what the most common mental health issues affecting refugee communities and the key logistical and clinical challenges that make effective support hard to deliver. Two, to describe current best practice approaches that improve access and support recovery for refugee communities, such as brief treatment, telehealth delivery, and models that can be used by a range of trained mental health professionals. And last but not least, to familiarise mental health professionals with the main resources available to support the provision of mental health services to our refugee communities. So without further ado, let me now introduce Emmeline, who will facilitate the rest of the forum. Working here at the Transcultural Mental Health Centre, Emmeline combines her clinical psychology background with her role as a mental health consultant in the Refugee Mental Health Program. Welcome, Emmeline.
Thank you, Nadia, and happy Refugee Week, everyone. Welcome all to today's TransFORUM. I represent the Transcultural Mental Health Centre's statewide refugee mental health program, and our annual Refugee Week TransFORUM events form part of the activities we undertake to achieve better outcomes for the mental health of our refugee communities. For those who have yet to hear of our refugee mental health program, it is about strengthening the mental health of refugee communities, including new and emerging populations. We collaborate with these communities and health professionals to build capacity, increase access, and promote culturally responsive mental health care. We are excited to have quite a large number of people registered today, and with so many questions already submitted, we've turned off the chat to help things run smoothly. The session focuses on the mental health and well-being of our refugee communities, so some questions fall outside of today's scope. If anything comes up for you, you're welcome to contact us or the presenters afterwards. Feel free to use the react button if anything said resonates with you as well. Please be aware that we will be discussing some difficult issues, so be mindful how this might impact you and take care of yourself. So let's get started. I'm happy to introduce Professor Angela Nickerson and Dr. Philippa Specker. And so I'll just, I'll get you to get your slides ready, Dr. Specker, and I'll just take a moment to introduce you and Professor Nickerson. There's the full biographies are available on the event page, so I'll keep this brief. Professor Nickerson is the Director of the Refugee Trauma and Recovery Program at the University of New South Wales and is a clinical psychologist. Dr. Specker is also a clinical psychologist and postdoctoral research fellow with RTRP. Together, their work focuses on understanding the psychological and environmental factors that shape the well-being of people from refugee programs and on translating that knowledge into policy and evidence-based clinical practice. Today, we're fortunate to have them sharing the key advances in evidence-based practice emerging through their work at RTRP. Their insights will offer practical knowledge that you can begin applying in your everyday practice.
Thank you so much, Emmeline. Am I good to go ahead?
Yes, go ahead
Fabulous.
whenever you're ready.
Great, okay. Thank you so much. And I really want to extend our warmest thanks to Transcultural Mental Health for inviting us to be here today, where we've enjoyed a long collaboration with the Transcultural Mental Health Centre and very excited to continue it in this way. I just wanted to take a moment to introduce us and our group, to tell you a little bit about why we're here. So as Emmeline said, my name is Angela Nickerson and I'm a Professor of Psychology at the University of New South Wales and also a clinical psychologist. And I wanted to take a moment to introduce the Refugee Trauma and Recovery Program. So RTRP is a research and clinical group that is staffed by clinical psychologists and research psychologists, as well as intercultural therapy assistants, interpreters, and research staff. And we've been going now for around about 13 years. We were established in 2013 with really a purpose of trying to build an evidence base regarding factors that influence the well-being of people from refugee backgrounds. And one of the ultimate goals, I'm a clinical psychologist, so when we started this was to make sure that we were using evidence to inform the best possible interventions we have for people from refugee backgrounds, to inform and develop culturally sensitive and evidence-based approaches to supporting good mental health in refugees. So as part of this, we have developed novel interventions. We've tested interventions in treatment studies with refugees living in Australia and in transit settings overseas, with the goal to identify the most effective and appropriate treatment approaches. Ultimately, what we're passionate about is bringing the evidence to practice. So we don't want to do work that just sits in journal articles on the shelves that no one reads. What we want to do is engage with people like yourselves, all of the people who are here today, who are really working with people from refugee backgrounds, so that we can learn from your experiences and share what the research tells us about how to give the best possible interventions to support people as they, continue their migration journey once they've arrived in Australia or elsewhere. We're also very passionate about using this research evidence to try to inform policy and to increase access for people who may not have access to evidence-based approaches. So that's just a little bit of background about us. I'm actually delighted to introduce my colleague, Dr. Philippa Specker. I'm talking about this research, but Pip is really one of the people who's actually been doing it. She's a clinical psychologist with over a decade's experience in undertaking clinical work and research with people from refugee backgrounds, from a variety of different backgrounds, both in Australia and also in Indonesia. And she's going to be speaking about best practice approaches to supporting mental health of refugee communities. So I'm going to hand over to Pip now, but I will be hanging around for the questions section and very much looking forward to our further discussions.
Great. Thank you, Angela, and thank you, Transcultural Mental Health, and also everyone who's attending today's talk. So let's get straight into it. So when we're talking about the mental health needs of refugee communities, let's start with the figures that we are seeing across the globe. And
sorry, Pip, just jumping in, have you shared your slides? Oh. Just to check that they're not coming up on the major screen that I can see.
Oh, okay.
Sorry, I know you're just getting started.
No, that's all right.
Emily, you can't see those either, can you?
I can see them. It's fine.
Oh, you can see them?
Yeah, yes.
Amazing. Okay, it's just me.
Fabulous. That's all right.
And we've got some attendees saying they can see. All good. Thank you.
Sorry, Angela, you're going to have to just get the audio version of this then. Okay, so in terms of the mental health needs of refugee communities, it's not news to anyone that they are often quite significant and quite complex. And as a piece of research that came out about 5 years ago really brought this home. When we talk about the levels of mental health problems among refugee communities, we're seeing a magnitude that we don't see typically in general populations. So for adult refugees, this research is telling us that about 28% might be experiencing anxiety, 30% experiencing depression, 27% experiencing PTSD. And similarly for children and adolescents from refugee backgrounds, we're seeing 32% endorsing anxiety, about 28% might meet criteria for depression, and among some populations up to 1 in 2 children and adolescents meeting criteria for PTSD. These numbers are big, and particularly when we compare them against the general population in Australia, where we see the incidence of similar mental health problems sitting between 1 and 7%. So we're seeing quite high prevalence of mental health problems for some members of refugee communities. And then it's really understandable then that we're also seeing quite high demand for mental health support. Part of what makes the mental health presentation and the mental health needs for refugee clients sometimes quite complex is also because of its relationship with post-migration stresses as well. So post-migration stresses refer to the daily living difficulties that refugees can experience in a resettlement country like Australia, but also whilst in transit. And we know quite robustly that these kinds of stresses exacerbate mental health difficulties, and sometimes even more so than the impact of past traumatic events, which we already know is quite significant. These are things like having an insecure visa, being separated from your family, the impact of housing instability and language barriers, discrimination, but of course also the stresses that would come with living in an entirely new country, navigating new systems, and parenting, for example, in a new country, really challenging. The way in which someone's resettlement experience might impact their mental health is very concrete and tangible for a lot of people from refugee communities. Some of the research that really stood out from the Australian context has found that, refugees who reported having to skip meals were 2 times more likely to have PTSD. And also some of the research that myself and Angela have conducted found that refugees who had spent time in Australia's offshore detention centres were up to 20 times more likely to have PTSD than refugees who had spent a brief amount of time in onshore detention before joining our communities. This is really quite staggering, and it highlights, when we're talking about supporting the mental health needs and the kind of solutions that are needed, it highlights the need for those solutions to be multifaceted. In particular, structural, political, environmental change. These things are critically important for supporting mental health for Australia's refugee communities. And when the environment and the policies improve for folk, we see carry on improvements in mental health. A good example of this was some research that Angela and our team conducted, which found that when refugees in Australia were able to transition out of insecure visas, so move from bridging or temporary protection visas onto secure visas like permanent protection visas, their mental health improved over time. So it's a really kind of clear example of when we're talking about improving and supporting mental health, this policy, political and structural change is one really important part of that picture. At the same time, we also need effective and tailored psychological interventions to help refugees cope with distress. And so that's what I'm going to really focus on in today's talk, because that's the area of expertise of our group. So when we talk about supporting mental health for refugee communities, we've got to start with acknowledging that there are some significant challenges in the provision of mental health care for this patient population. If it was really easy, this talk probably wouldn't exist. And one of the first challenges that's important to acknowledge is, starting from the beginning when we talk about therapy, is how we even conceptualize trauma. For so long in our field of psychological therapies for trauma-affected populations, we've really focused on this classical trauma concept. And this is a really important concept, it's the cornerstone of a lot of our first trauma-focused therapies that were developed for military and other kind of civilian trauma-affected populations. But what we find is that refugee experiences can look quite different to other client populations. These may be people who have an accumulation of adversities and quite complex trauma histories. And so sometimes this classical trauma concept doesn't always apply. So this idea really comes back to the thinking that, life is good, people go through life and there's we're pretty happy, nothing's going wrong. And then suddenly there's this one big traumatic event that happens to us. And as a result, we develop PTSD. And so inherent in this traditional concept of, or conceptualization of trauma, are some really important assumptions. It assumes that trauma is a single event that happens once. It assumes that it's a discrete event in the past. It happened and it's now totally over. Akin to, I had a normal life. I then went to another country to fight in a war because I'm part of military, and then I came home and now that's over. And the third assumption is also that people develop just one diagnosis and it's PTSD. And whilst this is really valid for a lot of client populations, and it formed kind of the basis of the development of a lot of our trauma-focused exposure therapies, like prolonged exposure, where we relive that single key traumatic event multiple times to help someone process it and reduce the symptoms associated with it. These assumptions might not ring true for refugee clients. In particular, this idea of an index trauma, there being one worst event to focus on in therapy, might not be meaningful for many refugee clients who've experienced multiple types of traumas across war, maybe during flight or displacement, so potentially trauma in the transit or resettlement country. This index or one trauma doesn't always apply for folk who've experienced prolonged trauma due to imprisonment, war, interpersonal trauma, which we know is often quite chronic. That relates to persecution, torture, rape, and of course, family violence, which is a really prevalent but often underreported experience for a lot of people from refugee backgrounds, because we know that at wartime, family violence also increases significantly. It also might not always apply for refugee communities in situations where the distinction between individual trauma and family trauma might not be as clear. And for many people, trauma may not have necessarily ended. They might still be living in a situation that's unsafe, in a transit or precarious kind of flight displacement environment, or they might be living in the Australian community as an asylum seeker, waiting for their refugee claim and confirmation of stability to be decided. Or they might have family or friends living somewhere else that's currently unsafe. And so for a long time, there's been understandable frustration among practitioners who are tasked with, supporting refugee communities, using psychological interventions, feeling as though some of the interventions we have don't really apply well to the people that we are working with. I want to, offer a very different conceptualization of trauma that's much more akin to the experiences of clients that I work with from refugee backgrounds. And that is trauma that might span the life course. This is a client whom I'm calling Samira, that we work together to do therapy. And you can see that over her life, there have been many significant traumatic events. When she was 14, she had a forced marriage. That marriage was characterised by marital rape. She experienced forced deportation due to being an ethnic minority during wartime and was assaulted by soldiers. She lived through missile attacks and bombings. She lived through quite really egregious domestic violence at home, which culminated in her being stabbed by her husband. She also made the perilous boat journey from Indonesia to Australia the first time the boat sank. And then the second time she was successful in coming to Australia, but then had a period of time in detention where she witnessed numerous assaults. So straight away we can see that, this experience is very difficult to apply the traditional conceptualization of trauma to. It's very difficult to sit down with Samira and say, okay, what's the one traumatic event that we're going to focus on in therapy? Because that's how therapy works for trauma. You can understand then, I think a lot of practitioners would feel quite frustrated and a bit confused in terms of how to approach treatment planning for someone like Samira. Now, there is good news though, which is that our most recent iteration of our PTSD treatment guidelines has really been able to capitalise on all of the research and the advancements in therapy that we've seen over particularly the last decade or two across the globe, that has done a really great job of recognising the different needs of different client populations and ensuring that there are therapies there that accommodate exactly these kinds of experiences. So in terms of where to look when approaching treatment planning for someone like Samira, the PTSD treatment guidelines that we've developed in Australia is a really fantastic place to start. This may be familiar to many people in the talk. It may also not be. So in the interest of not assuming any prior knowledge, these are guidelines that were developed by Phoenix Australia. This is the Centre for Post-Traumatic Mental Health in Australia. It's based in Melbourne. And these guidelines were developed with Australia's leading trauma experts, specialist practitioners who work with trauma-affected populations, and also individuals with lived experience. And so the way PTSD guidelines are created, including the Australian guidelines, is that a systematic review of Australian and international research is conducted. And specifically, they look for studies and clinical trials and other types of clinical studies to see what are the therapies that people are using, how do they work, do they not work, what is the quality of these kinds of studies, how confident can we be in the conclusions that these studies make, and then also hold that research evidence alongside some other important factors like what may be the benefits and harms for clients, what might patient values and preferences be, how feasible are some of these approaches, and how accountable are some of these approaches. And using all of that information, they developed quite an extensive set of guidelines. But for the purposes of simplicity, we can kind of distill them down into this kind of traffic light system, where there are some guidelines where we can give a strong yes to. There are some therapies that there are some therapies that we have really continuous, consistent, good quality, strong evidence to suggest that they work really well and work really well for a really big variety of people. And so these are the kinds of, we call them first line treatments. These are the strong yeses. Clinicians should provide the intervention to almost all patients in almost all circumstances where possible. We also have some amber recommendations, some conditional recommendations. This is acknowledging that sometimes our first line treatments might not be available, or there might be something really specific about the client population that suggests that we should actually provide a different intervention under certain circumstances. And this is where a lot of our talk is going to focus on in terms of what we do when we're focusing on developing treatment plans for people from refugee backgrounds. And lastly, of course, really importantly, it tells us if there's really strong evidence that something isn't working. So this is not just a situation where, there haven't been enough studies on this particular approach, and so we don't know. This is a situation where there have been enough studies and have consistently shown that the therapy is not working or doing harm. And that, of course, is really important for us to be aware of as well. So I'm going to provide a quick overview of these green, amber, and red recommendations, but we've also linked this guideline. It's a free online resource in the notes relating to this talk. So you can go and look at this in much better detail as well. So know that this is freely available information for everyone. But at a glance, it highlights for all trauma-affected populations that there are some green or first-line treatments. These are things like our trauma-focused CBT, prolonged exposure, cognitive therapy, cognitive processing therapy, and EMDR. And we also see for children and adolescents that trauma-focused CBT delivered directly for the child or adolescent, or delivered to both the caregiver and the child. These are all our green first-line treatments. These really have very, very strong recommendations. But what's most interesting for us is we get to the amber section. And these are therapies to consider when the first line might be unavailable, or if there's something very specific about the population or patient that you're working with. And in particular, I want to spotlight the inclusion here of a therapy called narrative exposure therapy. And the guidelines state that for adults with PTSD, where trauma is linked to genocide, civil conflict, torture, political detention, or displacement, we suggest narrative exposure therapy. And so this is one of kind of the newer updates to the guidelines that's acknowledging that for specific communities, particularly patients from refugee backgrounds or people with refugee-like experiences, narrative exposure therapy has a really strong evidence base, and it's suggested to consider this as a first-line treatment. Also, in the interests of completeness, the red section shows us now that individual psychological debriefing or group psychological debriefing after trauma. This is where people go in, immediately or very shortly after a traumatic event has happened and actually make people talk about what happened. We now robustly know that this actually makes it more likely that someone will go on to develop PTSD. So instead, we need to just provide information, emotional support, and practical assistance. Okay, so the key takeaway from the guideline is that when we're working with people from refugee backgrounds, narrative exposure therapy is a really a really valuable first line approach. Again, I'm sure that there are many people here today who know about narrative exposure therapy, may even be using it themselves. But in the interest of making no prerequisite assumptions, let me just briefly overview this approach. This is a therapy that Angela and I have been using when working with refugee clients in Australia for quite a few years now. And we were lucky enough to be trained by the original authors of this therapy. So narrative exposure therapy was developed by a team of therapists and researchers based in Germany in the early 2000s in recognition that they were seeing a number of clients from refugee backgrounds and experiencing the frustration I spoke earlier about in terms of noticing that they're working with people who experience trauma across their life course and wanting to actually really acknowledge that life course reality rather than focus therapy on just a single event. And so what they did was develop a therapy that was a really beautiful marriage between the exposure therapy techniques that we know that work, that are kind of what's the core part of our first line treatments, things like trauma-focused CBT and prolonged exposure, marrying these exposure therapy techniques in a larger framework that acknowledges the life course approach of trauma. So they married this with testimonial therapy. This was a therapy that was first kind of emerged in the 1980s in Chile for when therapists were working with former prisoners, people who had been held prisoner by the Chilean military and government. And they realised that by being able to sit down with these survivors and talk through from the very kind of testimony perspective what happened to them was actually really effective in together creating this shared testimony, which for them ended up being a written document, and noticing how that experience also allowed them to integrate their traumatic experiences with the rest of their life, to do emotional processing, to see improvements in self-esteem and see reductions in some of the psychological symptoms that we see among folk who've experienced egregious trauma. And so narrative exposure therapy holds these two tenets. It's a time-limited trauma-focused intervention that was developed specifically for refugees and conflict-affected populations. And it has these three tenets: psychoeducation about trauma-related symptoms, how these are normal reactions to abnormal events that have happened to someone; emotional processing of past events to reduce the symptoms that impair current functioning, but also doing this emotional processing to make meaning and find resolution in past experiences. And finally, to provide testimony regarding their human rights violations. So it takes a narrative lifetime approach to conceptualizing trauma, and it integrates both positive experiences and strengths with the traumatic events in someone's life narrative. And the important piece is that it works. We have a large number of clinical trials now across the globe that have tested this intervention with different refugee populations, and we've found it to be effective in reducing PTSD, very much so, quite significant large reductions in PTSD symptoms. Now, importantly, what we see with NET is that these benefits of therapy are most evident about a month after completing therapy. So it takes time after the end of therapy for the emotional processing to fully occur. And then about a month after completing therapy, we see these really big reductions in PTSD. And then those reductions are sustained afterwards, which is great to see. What's also really reassuring is there are a number of studies now that are showing NET to also be effective in reducing depression and anxiety for refugee clients as well. And that's really important because we also need to recognise that PTSD is unlikely to be the only mental health problem that is important to a client. Some key features about NET that's really important, and quite a big update compared to, what this talk might have looked like 20 years ago, is that we now are starting to see the emergence of therapies that are much more easy to implement for both the client and the practitioner than ever before. So NET is short. In these studies that found consistently for it to be effective, the average number of sessions that people were receiving were 6.5 90-minute sessions. So that's less than 10 hours of therapy in total for people's PTSD symptoms to halve, to fall below a level of diagnosis. That's pretty impressive, and not what I think I initially, 5 years ago, would have thought would be sufficient. And yet we're seeing consistently that when we are using therapies that are developed for refugee populations, they don't need to last years and years and years in order to work. We can actually do really good, effective work in a short period of time. They're also much more flexible in how to deliver. So NET's being delivered successfully face-to-face and also online via telehealth. Most of the work that I've done has actually been via telehealth, and that is in no way a barrier to its effectiveness. In fact, sometimes it can make it easier for people to join. The other thing that's really great to see is who delivers therapy. This is radically evolved in the last decade. It's not just psychologists that are the sole bearers of delivering therapy. NET is effective when psychologists deliver it, when other professionals deliver it, and also when lay professionals deliver it. So in my opinion, some of the coolest examples of NET being used is when, seeing it being used by fellow refugees to support their community in refugee camps. So a clinical team comes and supports people from the community in getting training in how to deliver NET and provides ongoing supervision and support. And then it is people from the community that are actually doing the NET sessions with their peers to bring about benefits, which is really great to see. The other thing that the evidence is telling us is that this is an appropriate and effective treatment even when trauma is complex and even when trauma is ongoing. So we don't need to wait for this kind of perfect, stable moment to commence therapy. This is effective, as I said, for people in really precarious and ongoing uncertainty situations like refugee camps. But we also see that this is effective even in Australia among folk who might be asylum seekers, who still have quite a degree of ongoing uncertainty and instability in their lives. So that's a really exciting update. And again, 10 years ago, we weren't yet confident if these are circumstances in which we can deliver therapy. And now we're consistently seeing that there's absolutely no reason not to. And it can actually be really profoundly valuable for people. So just to briefly overview what narrative exposure therapy looks like, it really has 3 core phases. It starts off by working with a client to understand the impact of trauma, by laying the lifeline, which I'll talk about in a second. The real meat of the therapy comes in the sessions when you construct a coherent life narrative together, walking through from birth to present day. And then in the final session, you relay the lifeline and explore hopes for the future. So practically, this might look like the first session, laying the lifeline, where if you're in person, you might lay down a rope and have stones and flowers with you. If it's online, you might do this visually, as you saw with Samira's lifeline on the screen earlier. And the purpose of this is really the rope or the line represents someone's life from birth to present day. The uncoiled bit is the future that's yet to happen. And the stones represent traumatic events in people's lives. Flowers represent positive events in people's lives. And you walk through together, starting at birth, moving up to present day, and working with the client to lay stones and flowers to represent these significant positive and traumatic events. And sometimes where relevant, people might put sticks on their lifeline, and this represents instances of perpetration. This is particularly relevant when that's being used with people, for example, who may have been child soldiers. So this is kind of the online version of what laying the lifeline looks like with Samira, because we did our sessions via telehealth. And then the main part of therapy are the reliving sessions, where you are integrating, constructing a coherent life narrative together. And so this is from birth to present day. You walk through the events of someone's life, and each time you get to a significant big stone, you use those exposure therapy techniques to relive that event and to facilitate emotional processing. So after you do that exposure, you also talk about the meaning of the event, you know, how that trauma impacted that person and how they carried that through their life following. What these sessions look like is an integration of the power of testimony as a practitioner bearing witness with a client to the human rights violations, providing that human connection, providing safety for the client to explore past traumatic experiences, sometimes for the first time, and restoring dignity. But it's also got those exposure therapy techniques, that deep emotional processing, allowing the expression of fear, shame, guilt, and anger to come out, fostering acceptance of these impossible choices that sometimes people need to make in these situations, and also making meaning of the past and understanding its impact on the present self. And then in the final session, it's relaying the lifeline and exploring hopes for the future. This is an opportunity to consolidate the life narrative and foster hope for the future. And in the final session with Samira, with her permission, included her kind of takeaway when we spoke about what she wanted to do after therapy in terms of this narrative that she's now created, which I also wrote, which, you know, the therapist also documents and writes down. And so the client has their life narrative that they take with them at the end of therapy. And she said, thinking of the future, I anticipate there'll be more stones, but I also have hope. I would like my children to read this one day. I want them to understand why I made the decisions that I did. They deserve to know and understand. My children also experience these very stressful events, so they deserve to know why I made these decisions. Thank you for listening to me, for believing me, and for supporting me. And also, I guess what's not captured in this quote was at the time of the final session, Samira's PTSD symptoms had halved. And by the time we checked in with her a month later, she no longer met criteria for PTSD, and her depression symptoms had also reduced, which is really fantastic to see. So when we come back to this idea of the classical trauma concept and how it can be really tough applying this for refugee clients, we can see that NET goes a long way in addressing some of these assumptions that might not fit for the groups that we work with. You know, in not focusing on just a single event in the past and not just focusing on PTSD, but being able to take a life course that can accommodate PTSD alongside other kinds of emotions that come with trauma relating to anxiety and depression. But NET's not the only option. And this next set of options I want to talk about are really in response to some of the other challenges that we face when trying to provide mental health care for refugees. And there's two key ones. Firstly, there are lots of common comorbidities. It's not just about PTSD. When we're trying to provide support, PTSD may be occurring alongside a whole host of other kinds of problems, or there may not be PTSD, and there may actually be other kinds of mental health complaints that a client might be bringing up, like anxiety disorders or depression, chronic pain, or these feelings of guilt and grief, emotion regulation problems or interpersonal difficulties, suicidality, cognitive impairment, family conflict, or somatic complaints or physical illnesses. And so we need to have therapies that are transdiagnostic, that are flexible enough to accommodate lots of different kinds of mental health complaints. Also, there are some really significant practical challenges. Structurally, there's a lot of people who are experiencing financial strain, might have, instability around housing. There's also language barriers. Some people have experienced educational disadvantage, being displaced, that disrupting their education. There may be confusion around how to access some of these more traditional kind of mental health services. And there may be some restrictions on working rights and things like this for asylum seekers, which can also make them feel less able to access other services. We also see that there's a number of cultural and refugee-specific barriers. Stigma can be really high, both stigma because of the mental health symptoms you're experiencing, but also stigma for seeking help. Also, for some folk, mental illness may be seen as a family matter. And so it doesn't seem particularly relevant or obvious to be engaging with health services for support, given that this is not kind of something that might seem like the logical place to go. There's really valid concerns around confidentiality. And sometimes there's worries that if an interpreter's from the same community, then their confidentiality might be impacted. People with insecure visa status in particular experience a lot more barriers in accessing and using services. And understandably, some folk may have distrust of authority figures after their own experiences of persecution. So we've got some, clinically, we've got a lot of comorbidities potentially, and practically, we've got a lot of barriers to work with. And so in recognition of this, the last decade, we've seen the emergence of this kind of suite of interventions called low-intensity psychological interventions. These are brief, structured psychological support that's delivered typically by non-specialist workers. So not delivered by clin psychs like me. They are culturally adapted. Typically, the content is culturally adapted CBT techniques or ACT techniques. They're designed for scalability in low resource settings and humanitarian settings. And they're shown to be effective in reducing PTSD, depression, anxiety, psychological distress, and disability. And so the key benefits here is recognizing that in a reality where there are often a lot of barriers and demand for mental health support might actually exceed the supply in terms of the available resources, we need to be really pragmatic in developing effective interventions for refugee clients that are scalable, that can reach large populations, that are culturally adaptable, available in multiple languages, that use kind of key metaphors and ideas that have universal meaning, that are transdiagnostic, that are relevant to multiple psychological presentations, so that someone doesn't need 12 different therapies for each of their 12 main mental health complaints. And they need to be cost effective as well. So some key examples of this are hosted on the World Health Organization website, and I've included links to this in the resources page following this talk. And there's a bunch of them now, which is really great to see. And all of these have been developed specifically for forced displaced populations. And so we're moving away from this kind of, 20 years ago, having therapies and interventions developed for other trauma-affected populations like military folk or civilian folk, and us kind of trying to awkwardly adapt them so it works for refugee clients. These are interventions that started with what are the needs of refugee clients in humanitarian and low resource settings, and how can we develop effective interventions for this group first and foremost. So some of them target younger ages, like early adolescent skills for emotions, and then some of them target a much more broad. So Self-Help Plus has a really wide age range, and it can be delivered individually or by a group. It can be delivered online or in person. One that I want to spotlight today is one of the World Health Organization's interventions called Doing What Matters in Times of Stress. And I want to spotlight it simply because it's one that myself and Angela are most familiar with, because we've recently implemented it with a group of refugees who are experiencing protracted displacement in Indonesia. we predominantly worked with Afghan and Iranian refugee communities in Indonesia. And Doing What Matters is a 5-week mental health intervention. People receive this illustrated workbook translated in their own language. And it's great because the workbook is not word heavy. There's a lot of cartoons. It's really quite digestible. And there's 5 lessons in it, 5 key coping with stress techniques from an ACT-based background. And participants received the workbook. They had links to some audio files of people walking through the technique. And they also got a call from a facilitator each week for 5 weeks to help them practice that skill and make a plan on how they can continue to use that skill in their everyday life. And these facilitators were refugees from their community that were part of our team that Angela and I have supported in training how to deliver this intervention and providing ongoing supervision. Also with another colleague, Gulsha Kurt, was really central to this supervisory team. And we did assessments with the participants before, during and after the intervention. And this was made possible by some really important partnerships with local and international NGOs and also a local refugee-led organisation. And the great news is it works. So people who received Doing What Matters in Times of Stress in our project, after completing the intervention, had significant reductions in PTSD, in psychological distress, reductions in functional disability, and had improvements in their well-being and their social functioning, which was really fantastic to see. And it's fantastic to see because there's nothing particularly groundbreaking about these interventions. There's no magic technique or therapeutic intervention that we haven't heard of before. They're using very simple but foundationally core coping with stress techniques. So in Doing What Matters, it's predominantly ACT-based. There are some other ones in the WHO suite that are a bit more CBT-based. But the first lesson is really focused on grounding, helping people connect with what's happening right now using grounding and breathing technique. The second lesson is on unhooking. So being able to recognize when you're getting hooked or caught up in your thoughts, and then using those grounding skills from lesson 1 to unhook. Lesson 3 is all about values. So being able to identify what are your values and what's within your control, and what are the ways that you can live in line with your values, what matters most to you, and how can you have value-driven action. Lesson 4 is all around kindness, working out how we would treat a friend in this situation if they were experiencing these kinds of problems or difficulties, and how we can extend some of that kindness to ourselves. So that self-compassion piece. And lesson 5 is about making room for those uncomfortable, unpleasant emotions. So, how can I allow this feeling to be present without fighting it? None of this is going to sound particularly new to anyone. And I think that really is kind of the power of these interventions is in their simplicity, in actually coming back to these foundational coping with stress techniques that time and time again we've shown to be really effective, but making sure that we're delivering them in a way that is accessible and culturally responsive. So again, when we look at the kind of core characteristics of low intensity interventions, we're starting to see a bit of repetition between some of the key updates that we saw in that. Firstly, these are short interventions. Doing What Matters is 5 sessions or 5 lessons. And again, they're really flexible in how to deliver them. They can be face-to-face, they can be telehealth, they can be individual, they can be group format. It doesn't need to be a psychologist. In fact, it's probably better if it's not. It's probably better if it's coming from someone in the community that's trained and supported by a team of practitioners. And again, the evidence supports their delivery even in precarious circumstances. We do not need to wait for stability. This was effective for refugees in Indonesia who experience extremely precarious living circumstances and have no legal recognition in Indonesia. So And that's not unique. This has also been found to be effective in refugee camps in Jordan and other countries. And it's also been rolled out in some health services in Iraq, for example. So really exciting updates. And a lot of this, none of this would have, if I was doing this talk 10 years ago, none of this would have existed yet, really. So really, really exciting. In terms of where to go from here, there are a number of really helpful resources that, coming back to the Australian context, that are really great starting points or returning points. And again, I want to spotlight the Australian PTSD guidelines. Specifically, the most recent guidelines have sections at the end of the guidelines on specific populations and trauma types. And there's one small chapter on refugees and asylum seekers. Again, I've linked this in the resources for those who might be interested, but to kind of distill some of the key takeaways from this guideline are some considerations for both assessment and treatment in order to provide culturally effective delivery. The first thing to note is when doing assessments for people from refugee and asylum seeker backgrounds, there's a couple of key domains that are important to touch on that we might not routinely touch on for other client populations. So asking about visa status is really important. This shapes someone's entitlements in Australia and likely is a key determinant of the kinds of daily stresses they may be experiencing. Asking about cultural background, again, really important, because this is often the battleground in which stigma might be fought. But also it tells us a lot about someone's causal beliefs, how mental health develops, and how to seek help when you experience mental health problems. Understanding about post-migration stresses is really important, even if it's got nothing to do with psychological interventions, because this does impact mental health still. So understanding people's housing, employment, legal situation, and potential isolation. Trauma history is a great thing to touch on. The guidelines recommend taking a thumbnail sketch approach. This is, instead of kind of going into enormous detail, it's trying to kind of take a bird's eye view and understand what are some of the different types of trauma that a client has experienced and what's the approximate duration and severity of it. Physical health is a really important interrelated domain when trying to understand mental health. And so asking about pain, potentially traumatic brain injury, somatic symptoms, or infectious disease can be really invaluable. And finally, the individual and the family are closely connected. We know that parental PTSD can affect children's outcomes. So it's really helpful to understand who else is in the family system. The guidelines also recommend the use of culturally adapted translated measures when undergoing these kinds of assessments. And the good news is a lot of the examples here are available in lots of languages. HTQ is Harvard Trauma Questionnaire. IES refers to the impact of event scale. STAR, MH, and MAPSS are also different screening tools and mental health assessment tools that have been developed for refugee and asylum seeker populations. Also, when we're talking about evidence-based treatment, the therapy that we're picking or the intervention that we're picking is kind of like the lyrics to a song. But also there's all these other factors that kind of influence the melody of that song. And in particular, the guidelines highlight the importance of building safety and trust. We're recognising that trauma survivors may distrust clinical settings. Explaining confidentiality and its limits is really important, and potentially trying to accommodate a longer initial appointment can be valuable. Addressing stigma directly is really important too. We need to normalise help seeking and use education, psychoed, and also shared stories from community members as a way to reduce some of that stigma. This is called contact-based approaches. So we know that stigma is easier to reduce when people are able to see others like them talking about and engaging with these kinds of services and practices. Acknowledging collectivist values is really important. Framing treatment in a way that focuses on how how the family unit can be supported is often much more meaningful. And in fact, I remember Samira, when we had our first session together and talking about her goals for therapy, it was that she wanted to become more emotionally strong in order to be a better mother to her children. So being able to really build motivation around engaging in an intervention, not as this kind of selfish thing that you're doing for yourself, but rather something that by supporting you, we are able to support the family unit. When working with interpreters, we know that they can really help to facilitate effective treatment, but also it's important to check the client's comfort with this, particularly sometimes people might be worried about confidentiality, and being able to really address that and dispel concerns is important. And of course, as we mentioned earlier, moving beyond PTSD. But the key thing that is really highlighted throughout this chapter is that a core component of our treatment plan needs to be an evidence-based treatment, like what we've spoken about earlier. All right, so as we come to the end, there are a couple of key takeaways, because I recognise I've spoken a lot. So if there's nothing else that you take from today's forum, may it be just this slide, which is firstly that we now have a number of effective mental health interventions for refugee clients, which is amazing. In terms of our higher intensity interventions, there's narrative exposure therapy. And in terms of our lower intensity interventions, we now have a suite of culturally adapted ACT and CBT based interventions. Ones from the World Health Organization are a good example. Our team also created a refugee adapted skills training in affect and interpersonal regulation, so emotion regulation focused one as well. And there are others out there as well. But the good news is that these interventions are flexible and easy to implement. They're brief, typically 5 to 10 sessions max. They can be face-to-face or online. And some of them, especially the low intensity ones, are available in over 30 languages already. And finally, you don't need to be a clinical psychologist to deliver these interventions. But importantly, what is needed is initial training and ongoing support and supervision. This is really important to make sure that the interventions are being delivered as they were intended to be delivered, so the clients are getting what we know works. But it's also really important so that practitioners are supported in doing this work, because this can be really difficult work, and making sure that the mental health and well-being of the workforce is also acknowledged is a really important thing for a workforce to be sustainable. This is relevant for all levels of the profession, from clinical psychologists to peer workers. It's really important that there's ongoing supervision and support available. And there are lots of free resources available to guide and support you. I've spotlighted a number of these in the resources tab afterwards, and Emmeline's also going to touch base on this as well. So as I finish up, I do want to acknowledge the enormous team that stands kind of here in spirit, but not in body, that we work with at the Refugee Trauma and Recovery Program. And of course, I want to thank everyone who's attended today or might watch this later online. I know just how busy everyone must be, so taking the time to come to something like this or watch something like this is really appreciated. And I speak for both myself and Angela when I say that please do feel free to reach out to us if you have any questions at all. All right, that's it from me.
Thank you so much, Professor Nickerson and Dr. Specker, especially for such a practical presentation of what we can do for assessment, treatment right now with the people that we support. I think seeing how much is available for free that's been found to be effective while being flexible in delivery is very exciting, even if we're not a clinical psychologist, but have appropriate supports to do them. And it was nice to see some of the resources I did come across before. I think what was interesting was to see the Doing What Matters, having come across that firstly during COVID and seeing it being repurposed. I think that's really great to see. Simple, effective, and foundational stuff. So it's really great. It was also interesting to see, I guess, options like NET being short, easy to implement, again, being flexible. But so as Dr. Speck has been talking about resources, so I just wanted to add to the resources that are available to support health workers, given that there was a lot of questions focused on that that might be useful. So let me just check that we're about to share screen. So let me add to the resources. So for those that aren't aware, our Transcultural Mental Health Centre has a range of clinical services and programs, including the Refugee Mental Health Program, which I sit in. If you wanted to learn more about our services and programs like our clinical consultation service, the Transcultural Mental Health Line, please get in touch and we can provide an in-service for you and your organisation to understand how Transcultural Mental Health Centre might assist. And today, we are excited to announce that we will be collaborating with the Refugee Trauma and Recovery Program to run a community of practice for transcultural mental health practice supporting new and emerging refugee populations. It is for New South Wales health staff. It will focus on supporting the implementation of culturally responsive evidence-based approaches that advance mental health practice in the healing and wellbeing of people from new and emerging populations. So it'll run bi-monthly on a Wednesday at lunchtime, starting on the 19th of August. What we'll do is when we email all the resources, we'll also email the expression of interest form. And so if you are interested and eligible to join, you can please complete the EOI. We will also send, so just talking in terms of, the interest of building capacity, information of an upcoming workshop that's being run by us in collaboration with the New South Wales Refugee Health Service on the 28th of July. Or just feel free to get in touch about any other opportunities for professional development if you're not able to join either of those opportunities. Before we start Q&A, we value feedback here. So please scan the QR code or grab the link to complete our evaluation form. We'll send that with the email as well with the resources. And you can also let us know if there's any topics or issues for future webinars via that feedback form. Okay, so we actually have a really good amount of time, of about 20 minutes to do the Q&A. There's been a real range of thoughtful and important questions that have come through. And what I found, just looking at some clear themes that have come through that, really reflecting the realities of working with refugee communities. There was questions around access to care, especially around telehealth and system navigation, culturally adapted trauma treatment, the needs of specific groups like children, students and neurodivergent clients, building trust and trauma-informed practice, and finally system level collaboration and how services can work together to meet emerging settlement challenges. So with the scope of today's talk being focused on building service capacity and evidence-based practice, some of the questions and topics would be better responded to outside of today's session. And some of that information you can actually find on our Transcultural Mental Health Centre website, specifically within the TMHC Knowledge Hub. That might be able to help you with sort of the needs of specific groups. And if you can't find the information, you're more than welcome to get in touch with us and we can point you in the right direction. Okay, now we can start the questions. So to kind of help extend and I guess or consolidate what you've just been presenting, Dr. Specker, I'm going to pose a question to both you and Professor Nickerson. Given barriers such as language, digital literacy and systemic challenges, what strategies, particularly in telehealth, brief interventions or community-based models, have shown the most success in making mental health care accessible and client-centered for refugee populations?
Angela, do you want me to make a start and then I'll throw to you? Okay, so absolutely. I think being able to recognise the unique barriers that different clients are experiencing and then tailor the level of intervention intensity to what might be feasible for them is a kind of a really helpful starting place. So in an Australian setting where someone might be accessing a service that has mental health practitioners that have a lot of training and support and time, things like narrative exposure therapy may be a really good candidate, and checking that a client has interest in that is a good way to go. But you might find that someone doesn't have the interest or the time, or it's a different kind of service in terms of how much support and kind of practitioner to client facing time is feasible. And so some of these lower intensity interventions can do a lot of good with a lot less resources. So this might be really great candidates for folk who are experiencing poorer time, or some of the barriers that might make it difficult for them to enter in that more kind of traditional therapy engagement. So I think that's a really helpful starting point. Ange, is there anything that you wanted to add on this one?
I think that's beautifully put. I think the tailoring is really, really important. And Philippa covered, a lot of things in relation to this in her presentation in terms of access and so on. But I think what we're seeing now is people becoming much more creative and challenging the way that we've traditionally thought these things have to be done. And telehealth, I think, is a really good example of that, where, we started doing this work around telehealth, which was during COVID. We were like, is this going to work? Is this the right modality? And then our finding that actually it overcame a lot of barriers for people who were not able to be physically present to access the service physically, for people who had childcaring responsibilities or caring responsibilities. And so I think we are at a time where there are a lot of advances in terms of methods of delivery, and also this evidence base that we have that Philippa mentioned around these sort of scalable and low intensity interventions. We have a lot more options than we've ever had before in terms of what is evidence-based and can make a difference. And so I think Pip's point around tailoring it, both in terms of the client factors, the clinician or provider factors, and the service level factors, there's a larger menu of options than we've ever had before in terms of being able to put something together that's going to really be appropriate, meaningful, and feasible.
Thank you. I don't know what to add to that. I was going to say something from, I guess, the perspective of like having worked through the COVID period and seeing how quickly things were able to be shifted for telehealth, and then look at all the, I guess, going into the future, what it's actually helped with in terms of the research that you're doing and the implications. Okay. Another question from the audience was, what practical strategies help build trust, reduce unconscious bias, and avoid re-traumatization when working with transcultural communities?
It's a really great question. And of course, we have these fantastic guidelines that say it's really important to build trust and safety. And then you go, okay, how do I do that? Borrowing from both my clinical experience, but also some of the really fantastic research that we also have in working with other communities that may also have similar concerns around trust, particularly First Nation communities. One of the biggest takeaway I get from a lot of that work is not assuming from the get-go that people will trust you. I think a lot of the time as practitioners, we come here because we really want to help and support folk, and we assume that's kind of inherently obvious, or also assumed by our clients. And so being able to actually not take that for granted and ensure that in our early sessions we are checking how much someone has engaged with a service like this before, or spoken about mental health problems before, or gone to other services, trying to understand what those experiences were like for them, trying to be really clear about what we can offer and also what we can't offer, and what goes beyond the scope of what we can provide, and being really transparent around how your service operates in terms of what they can expect, how often they can see you, how they can contact you, what are your obligations in terms of confidentiality and duty of care. Being able to provide this information briefly but transparently is really helpful, so that everyone has a shared understanding of what to expect moving forward. And I find that a lot of the time, in my experience, trust is often built by me being really clear on what I'm not good at, or what I can't do in our sessions together, so that we're quite frank on what our shared goal is. The other element is also working with others as well. Our team is a beautiful mix of clinicians, researchers, and also interpreters with lived many with lived experience as refugees, and being able to work with them and learn as much from them as possible in how to initiate contact and how to maintain engagement in therapy has been really, really handy for me personally as someone who is not from a refugee background. And was there anything you wanted to add on that?
Beautifully said. I don't have anything to add. Thanks. Yep.
And sorry, Nadia, I forgot to ask you for the previous question, but I will ask you in relation to this question, if there was anything you wanted to add from our transcultural perspective.
I think the thing that that I'd like to add is, and what keeps coming up is, we over the years we have always looked at working with refugee communities. And the presentation today is that there is a lot of knowledge and skills. It's about adapting it and making it approachable for the community that we're actually. I'm thinking I've lost. Oh, sorry, I didn't know whether I've lost AV. So I just want people to also understand that they've got a lot of the skills, and it's about working through and enhancing those skills, or modifying or adapting those skills for the communities that we meet. I think what's really wonderful is exactly what you just said, Philippa, is that you don't come from a refugee background, and yet you've been able to use your skill set to be able to work with communities who are experiencing trauma. I think the approach, like the narrative therapy, means that there is it's adaptable for different communities. It crosses cultures. It's not one particular group will respond to this. And I think that from a transcultural perspective, that's what we're always looking for. It's about having, something that you've got as your core, and then you just slightly adjust it, and it might look slightly different how you might implement it with the community. So I think that's what resonated with me throughout today's presentation is the ability for the scope to provide services for refugee communities is all of our responsibility, because at one stage or another they may not be coming to us at that pointy end of care. They will be engaged with health services along the way, whether that be GPs, whether that be with community health services, whether that be at hospitals, or just in education, or wherever they might be. We have an opportunity to connect people to services and be able to address that, so that they can live really wonderful lives that they want to live, rather than having this impacting on their quality of life. So it's been a wonderful presentation. So I do appreciate that.
Thanks, Nadia. So I'll go to the next question. So many refugee, and you've kind of probably touched this on in the presentation, but maybe we can sort of consolidate the learning. Many refugee experience complex overlapping traumas, and traditional therapies may not always be effective. How does RTRP balance evidence-based interventions with cultural adaptation to ensure both efficacy and relevance across diverse refugee communities?
Thanks, Emmeline. Another really fantastic question. One of the things that I often keep in my head is when we talk about really good music, it kind of has two components. I think I briefly touched on this in the talk, where we've got our lyrics and then we've got the melody. And so a lot of the time I think about the way in which we kind of provide really good interventions or make really good music is we need good lyrics. This is about evidence base. We need to be using therapies that we have really high confidence work for the people that we want it to work for. But at the same time, there's so much involved in the melody, in how we deliver these techniques or these active ingredients, how we actually deliver it for the person in front of us. And that considers a number of things. It considers the clinical experience of the practitioner, what kind of supports they might have available. It considers the client preferences, and also the barriers and what kind of engagement is going to be feasible and practical for them. And so we can have these lyrics, net therapy, for example, or these low intensity interventions, but it can sound really different for lots of different clients based on what kind of melody we put with that. So thinking about how we're delivering it for the person in front of us. And I think this is the part where all of us as practitioners are really valuable, because these interventions need people to bring them to life. And so we do the work of being able to work out, based on the menu we have in front of us of different lyrics, I guess, and based on the needs of the person in front of us, we do the work of trying to make that a really good marriage. And that's where I think a lot of the movement has been in the last 10 years of how we kind of bridge that gap. And I think that's a lot of the space where I think there's so much more scope for us to support our workforce in doing it, because that's a really tough job, making those decisions and being able to kind of bring that melody to what's otherwise, you know, kind of a fairly standard lyric set. So I'm not sure if this metaphor has completely lost everyone, in which case I'm so sorry, but that's how I think about that particular dilemma, or I guess challenge.
If I can add to that, I guess the flip side is that for clinicians or people working in the space, when you have a songbook that can look so big, it's like walking in and going, I don't know where to begin. I think when things have been tested, when you've got a shorter playlist or someone's recommended that playlist to you, I'm just going along with this. I think it makes it a lot easier. It makes it a lot easier to kind of make decisions knowing that there is an evidence base behind it, that you're not coming at it from how did I come up with this idea to approach this? It creates those circumstances to be able to make informed decisions in applying it to the communities that we're working with, and I think having that playlist makes a big difference. So I do appreciate it.
I love this metaphor. Oh, sorry, Emma, let you go.
I was going to say exactly the same thing. I was going to add anything.
I was just going to say, I think it's a beautiful metaphor, but I also think that this question is the exact reason we founded our centre, right? It was because we saw this gap. We saw that there were evidence-based interventions out there for people who'd been exposed to trauma that looked nothing like the clients that we were seeing. And so what we have seen over the last, 10 to 20 years is it's no longer the case that we're taking interventions that have only been tested with people who have experiences that are less relevant to the refugee experience. Now these interventions are being tested with people from refugee backgrounds, and we've learned a lot, and we're learning more and more every day about which aspects of these interventions are most effective, how we can adapt them to different groups, what's feasible, what's safe, what's effective. And I think it all comes from the same place that we're all at, where we want to provide the kind of service that's the most powerful, effective, and efficient and sensitive. And so I do think our songbook is getting more refined. And we know that we have a lot of really good options in here. And I think this combination of drawing from the evidence is a really important component. But as Philippa has outlined, that goes alongside also clinical expertise, and it goes alongside client preferences and factors and values and so on. I think when you put these three things together, you're starting in a really good position.
That's very well said. Thank you, Professor Nickerson. So lastly, looking forward, what might be some opportunities you see that enable a mental health system for refugee communities to thrive?
Yeah, so I think what's been so exciting is how much the field has moved in the last little while of actually starting with refugee communities at the centre and ensuring that interventions are tailored to that experience rather than this kind of awkward adaptation from other client populations. And so that's been really radical, and we've already learnt, we've got a bigger menu now. We've also got it's a lot more options for different kinds of like intensities and levels of entry. So this has been really fantastic, but it's also true to still acknowledge that we still have room to go. These interventions are our front line, so they're the best available at the moment, but that's not to say that they work 100% for every single person. And so we're still trying to move in this space now of twofold, how we can actually translate the updates in the research to make sure that people on the ground are aware of them and really supported in being able to use and try these things out if that's something that interest them. And that often takes a while, but that's a really important next step. And then the other step is also how we can continue to understand who these interventions work for and under what circumstances are best, so that we can become more precise in how we make that selection between picking something off the menu and giving it to the right person in front of them. So I think those are two really important kind of avenues to continue to evolve. But I think that one of the things that I really stood out to me when I way back when was kind of just about to apply to do my clinical training, and I already knew that I really wanted to work in this space. I remember talking to a client who conveyed the idea to me that he very much felt that his mental health difficulties were too complex and too difficult, that treatment was just, they were beyond treatment. And I think the biggest takeaway that we're seeing is consistently in research, we do not have a presentation that is beyond treatment. Someone can have a lot of complexity, they can have a lot of trauma, they can have a lot of structural or cultural barriers to engagement in treatment, and we still have something on that menu as a potentially relevant starting point for them. And I think that is also not insignificant in terms of getting to this stage now.
Yeah, I mean, thank you, Pip. I think that's a beautiful way to kind of reflect on that question. And Emmeline, what a question it's just such a small question, right?
Yeah, it is. But it's a huge question. And yeah, I mean, Dr. Specker answered that so beautifully, and I'm sure you can add to it as well.
No, absolutely. Look, I think that for me, you know, changing tack a little bit, but these collaborations are extremely important. So the work with transcultural mental health, but also any of the work that we do with people who are really working in services, working in the front line, seeing the clients, our ability to generate information that's going to be useful is only possible if we're talking to people and understanding, okay, you know, we've got this intervention, but this doesn't quite fit with my service, or this looks a little different when I apply it with this group of clients. So I think this combination of drawing on, bringing together practice, service provision, implementation, alongside the evidence, these things shouldn't be separated. Bringing them together means that we're asking the right questions and we're learning, I think, equally as much from everyone, you know, who's listening today, even though I know you're not able to speak, but we learn equally in that way, that bi-directional information. So I think for us to become more attuned to what's going on out there and how people are applying things and the problems and barriers that they're encountering helps us to design research studies that answer kind of the next set of questions. So I see that as a really important frontier for improving what we're able to do.
And if I can just add to that, I remember the conversations right at the beginning with Angela when RTRP was being set up. The things that change in the sector are good relationships that are built over many years, of asking the tough questions, of being able to approach things from a way that is really authentic, but also thoughtful about the whole sector, about the people that we're meeting and their needs. And so it has been a wonderful collaboration over all of these years. And now to see it, as I bring it back to the community of practice, it's really exciting to see that the community of practice is another stepping stone to build the capacity across the sector, across New South Wales. That's always been the transcultural mental health work that we have done over 30 years, and that we're trying to continually do that. We are but one in the whole mental health journey of people, and we need to build the sector and people across all fields and service providers to be able to meet the needs of our growing and changing populations. Our refugee populations change all the time. Sadly, they continue to grow. Sadly, they come from all different regions around the world. And so it's important that we keep this on the agenda, and I appreciate the work that RTRP, particularly led by Professor Nickerson, has made and contributed to the sector over the many years. So thank you for your work. We really look forward to everybody participating in or sending their expression of interest in the community of practice.
Thank you. And on that note, it's 1:30. So thank you so much for being generous with your time, Professor Nickerson and Dr. Specker. Was there any last I don't know, last words that you wanted to add, although maybe we won't ruin the last things that you said. I'm sure it wouldn't. I could sit here all day just listening to the both of you.
Just a big thank you on my end as well. So thank you to Transcultural Mental Health for this, and also to all the attendees. Really appreciate the opportunity to share this.
Absolutely, completely agree with Philippa. We're really delighted to be here and really look forward to seeing what the next steps, how these emerge.
Yes, so look, thank you everyone for coming along today. We will send an email with all the resources mentioned today, including the EOI for the community of practice and the evaluation form. And a link to access the recording will be sent in due course in case you wanted to revisit the talk or share that with colleagues who weren't able to make today. Happy Refugee Day for Saturday to everyone, and wishing you a good day ahead.